Okay, this is Dr. Hall. We're going to move into Unit 10, talking a little bit about healthcare organizations. So I'm going to structure this lecture a little bit differently than the book does. My computer is making weird noises at me, sorry. And so the way I'm going to look at it is we're going to talk a little bit about the scope and diversity. What are the healthcare organizations that we have in our country? Then we're going to talk a bit about access, which is not something that the book covers, quality, and then ultimately coordination, which is also a little bit different from the textbook. So let's talk about the scope and diversity. So what are the healthcare organizations that we primarily have in this country? So inpatient facilities, remember, this is the type of healthcare where you stay overnight. So you stay for at least 24 hours. You are inpatient. You are kept in-house. So certainly we all think of hospitals when we think of inpatient facilities, and they are a really important part of our healthcare systems. So in terms of hospitals, we have several different types of categories of hospitals. So I'm going to start with general hospitals, which you can see in the, well, they're all blue. So this one right here. So general hospitals. General hospitals are not just an old soap opera from television, but it's also kind of your general workhorse hospital. It will have most of the services that anyone needing acute hospital care will need. But if they have a particularly difficult or tricky situation, a really complicated trauma, or they need some highly specialized open heart surgery or something like that, then they will often be referred on to a tertiary care hospital, which is the next one that you see up the list. So by way of example, for general hospitals in our region, the closest ones that we have to Menominee would be in the Eau Claire region. So Luther Hospital, which is run by Mayo Clinic Health System, and Sacred Heart Hospital, which is run by HSHS, which is like the Sisters of St. Mary, and Prevea Health. So it's an interesting conglomeration. So those are kind of your full service hospitals, but they don't have this super duper specialized care that you might need on occasion. So tertiary care hospitals that we would have close to us would be in Minneapolis, and of course down in Rochester at the big Mayo Hospital. So you notice that there's one before general hospitals, and that's critical access hospitals. And in fact, that's what we have here in Menominee. So these are small hospitals. Historically, they've sometimes been referred to as cottage hospitals, or in other countries, they're often referred to as cottage hospitals. These are hospitals that do not have the full suite of services available. They may not have all the different types of specialties. They often don't have ICUs. They may or may not have labor and delivery or maternity care or a birthing center. Our hospital here in Menominee, which is also run by Mayo Clinic Health System, does have a birthing center, but they don't have some of the higher acuity level of care. They don't have as many specialists, and they aren't capable of taking care of highly ill patients, right? So if you come to the hospital here in Menominee, they can take care, if you need your appendix out, they can totally take care of that. They do knee replacements, they take care of people with pneumonia. But if you get really sick, and we've had this happen even with some college students. We had a student get septic from a kidney infection. They needed to be in the ICU, so they got transferred to the hospital in Eau Claire, where they actually have an ICU. Okay, so those are kind of those three category of hospitals. And then you can see down below, I've got those specialty care hospitals. So these are hospitals that have decided they're just going to focus on one specific thing. So for example, you might have heard of Cancer Centers of America. That's, you know, they're just focusing on treatment of this one specific type. New York City, there's a hospital for joint surgery, right? So you sometimes have hospitals that just focus on one specific thing. So those would be specialty care hospitals. So those are our hospitals. And it's important to note that in the United States, the vast majority of our hospitals are actually nonprofit systems. So even though they deal with vast sums of money, they are not there to make profit for shareholders. In fact, they are nonprofit organizations. About 90% of hospitals in the United States are nonprofit. Some of those specialty care hospitals are a little bit more likely to be for-profit hospitals, although a counterexample to that would be St. Jude's, which provides care to children for free. So it varies. We also have, in addition to hospitals, we also have other residential treatment centers. And so I'm going to talk about skilled nursing and rehabilitation facilities first. So these are places that you might go after a heart attack or after a stroke or after a hip replacement surgery. You're not well enough yet to go home, usually because you can't do what's called your ADLs, your activities of daily living. You are unable to get yourself to and from the bathroom. You cannot do toileting by yourself. You are unable to feed yourself. You're unable to dress yourself, brush your own teeth, do the things that we all need to do just to live. So if you can't do your ADLs, or if you need an intensive rehabilitation program like with physical therapy and occupational therapy to help you get there, then you're going to go to a skilled nursing facility or rehabilitation facility. And the goal there is to rehabilitate you and help you continue to recover. You don't need to be in the hospital per se, and you might need some services that generally hospitals don't have. But then you're going to be going home, right? You're not going to be staying there long term. You're going to get better, and then you're going to go on and go back home. You're going to be able to take care of yourself, or so have you. So what? The other is nursing homes. So nursing homes are providing custodial care. So this is care for people who are not anticipated to be able to recover their ability to live independently. So people who need assistance with their ADLs, and it's not anticipated that they will improve. So of our nursing homes, usually about half of the residents in nursing homes need assistance with eating and feeding. About half of them are incontinent, right? They cannot control their bowel and bladder, so they need a lot of care. Now, it gets a little tricky because then there are also assisted living arrangements. So assisted living arrangements are not per se healthcare facilities. They are usually apartments or sometimes apartment buildings or other types of housing arrangements where there's some support. So maybe there are communal meals in a dining hall, maybe there are meals delivered, maybe there's someone checking in on you and helping you remember to take your medications every so often. So assisted living places sometimes have healthcare or medical care workers on site. Sometimes they have medical professionals, sometimes they have nurses, but sometimes they don't. So it varies, just to keep everything confusing. To also make it more confusing, oftentimes the same place will serve both as a nursing home and as a skilled nursing or rehabilitation facility. Because you need a lot of the same infrastructure. So oftentimes after someone has had a hip replacement, they're not yet fully mobile and able to walk on their own. They will go stay in the physical building of a nursing home where they have all the type of care aides and nurses that one would need. But the anticipation is not that they're going to stay there long term. They're just there until they get better. So sometimes these two types of facilities are combined into one physical facility. And to make it even more confusing, sometimes those places will also have assisted living. So you can have this kind of continuum of care depending on where you fall on the spectrum. Okay, the last type of facility I'm going to talk about is hospice centers. So hospice is referred to the care that we give to people who have been given a terminal diagnosis. So to qualify for hospice in general, it's anticipated that the person is going to live for fewer than 6 months, that they will likely die sometime within the next several months. And most hospice care then is delivered in the home through hospice workers and visiting nurses. The goal of hospice care is to provide comfort and palliation. The goal is not to extend your life. So you may still be getting medical therapies, but the goals are to keep you comfortable and peaceful as you end your life. Some hospice centers are residential or inpatient facilities. So that's why this is on this list, although the vast majority of hospice care that occurs in this country happens in the home. In terms of outpatient facilities, we have a whole huge mishmash of different types of things. So the solo or small practice, the old country family doctor of yesteryear, where they called it hanging a shingle. You just put a sign out, the doctor is in, and people would come see you in your little office, and you might have a secretary or a nurse assisting you. That mode of practice is not a financially sustainable model in most cases, although not all in the United States. And so those solo practices are increasingly uncommon. You do still sometimes find them, and also small practices where it's a couple of providers working together. We still do see those in terms of optometry offices, dental offices. They're pretty common still because the financial models are a little bit different for those, and it is a sustainable way to practice. But for medicine, it doesn't work very well most of the time anymore. You sometimes do see small group practices for physical therapy. Oh, of course, chiropractic is often a solo or a small group practice as well. Then there are multi-specialty groups. So this would be groups of healthcare providers. You might have some primary care providers, such as pediatricians, internists, family doctors, and maybe a couple of surgeons or a gastroenterologist or some OBGYNs kind of coming together to form a larger practice. So these multi-specialty groups. Oakleaf in Eau Claire is an example of a multi-specialty group. They are not owned by a hospital or a large health system. They have formed their own kind of mid-sized organization or corporation. And then the biggest one is the health system clinics. So for example, Mayo Clinic Health System operates a big clinic here in Menominee. We also have a small clinic that's operated by Marshfield Clinic. So Marshfield Clinic is a big, huge health system, and so they have a satellite clinic here in town. So health system clinics are for most of medicine, a more financially viable way to organize, especially primary care, as well as other outpatient services. So we're kind of seeing more and more of those. The fourth group that I have here is community health centers and free clinics. So there is some governmental support for these types of efforts, which are usually targeted toward people who don't have health insurance or who might be on Medicare and Medicaid and are unable to access care at some of the other facilities for reasons we'll get into in a minute. So yeah, those can be great adjuncts to how we bring care to the population. So this kind of brings up this idea of, well, how are they funded? So all of these healthcare facilities are primarily funded by reimbursements from the patient's medical insurance, right? So their health insurance pays, and then whatever the health insurance doesn't pay, then the patient is responsible for. So we have kind of two main types of insurance. There's private insurance, which is usually insurance that you get from your employer if you're benefits eligible and your employer offers that to you as a benefit. Or you can get it through the marketplace. So recall the Affordable Care Act established these healthcare exchanges to make it easier for people to get health insurance who didn't have access to it through an employer. And so those people are also on what are termed private plans, as opposed to, for example, public insurance. So these would be programs like Medicare and Medicaid. We'll talk about these more when we talk about health insurance. In the state of Wisconsin, Medicaid is often referred to as Badger Care or Forward Health, so you might know it by those names. Public health insurance is usually provided to people who are low income, right, or no income, or permanently disabled. And so it's paid for by the state, generally in conjunction with the federal government. It's kind of complicated, but it's paid for by the government using taxpayer dollars. And so, of course, these programs aim to be as cost efficient as possible, but that also means that oftentimes, especially for outpatient care, the amount of money that they pay the doctor or physical therapist or whoever they may be is often less than the cost of care. So what happens is that oftentimes, for example, if a physician opens a practice, and usually if half or more of their patients are Medicare and Medicaid patients, they will go out of business because they don't collect enough revenue to meet their operating costs. So it gets a little tricky, especially in the outpatient realm, especially in primary care. And of course, patients themselves. So depending on your health insurance plan, you most likely have co-pays, co-insurance, or deductibles, all fascinating things we'll talk about in the next unit. And then, of course, any other costs that are not covered by the insurance plan for whatever reason, including perhaps that you don't have one, right? So if you don't have health insurance, then the bill is coming to you, and whatever you pay to the hospital or the clinic is helping to fund that hospital or clinic. So healthcare is really expensive in this country, and there are many reasons for it, and some of them are unique to the United States and some of them are not. So a few of the reasons why healthcare is so expensive, because it's super complicated, is one is that staffing, right? So these are highly trained professionals who are making high salaries, right, in order to be competitive in the market. And in order for them to be able to pay off their medical school loans, you have to pay them a certain amount of money. So, highly trained personnel that require high salaries. So that's part of it. It's interestingly a small part. Equipment and supplies is not insignificant. So a standard exam table, for example, for a primary care office costs about $2,000. Which is kind of crazy to think about. So, everything from the swabs for swabbing people's throats to the sinks in every room, to the speculums, to the gloves, to the masks, to the blood drawing equipment, to injection equipment. If you're going to be freezing warts, the little cryo gun for the liquid nitrogen. And if you're a surgeon, well, then you're going to have all other kinds of supplies. If you're a hospital, you're going to have emergency rooms and ICUs that have incredibly complex and expensive equipment and drugs and medications that you need to provide. Operating rooms are exceedingly expensive to kit out, to outfit, to supply, and then to maintain. So you've got highly trained and expensive staff. You have really expensive supplies and equipment that you need to purchase and maintain. And then, especially in the case of hospitals, you need to have this equipment and staffing available at all times, or hopefully available most of the time, because you're trying to meet the demand for care, right? Your goal is to improve care to your population. You're a nonprofit organization most of the time. But if you have a hospital bed sitting empty, you are not collecting revenue, right? So think about it as, you're still paying a nurse because somebody might come in and need that bed. But so it gets really tricky because you have to maintain some excess capacity. Oftentimes in the United States, we would say that we don't maintain enough excess capacity, and part of that is because it costs you money. But the other reason why healthcare is so expensive in the United States, and there are more reasons than this is just a sampling, is that many bills go unpaid. So in fact, when it comes to hospital bills, it looks like probably at least half of them never get paid. Why do they never get paid? Well, because people don't have health insurance, or if they do, the health insurance doesn't cover the full cost of the bill and the patient is unable to pay the remainder. So let's just look at an example. So my son had a bad sore throat a couple of weeks ago, and it was the weekend. And we thought, well, he needs a COVID test for sure. And we wanted to get results back as quickly as we could so that we knew whether or not he could go to school and all those types of things. And so we went to urgent care at Prevea on the weekend, and we had a lovely experience. Everyone was very kind and very nice. And he got a COVID test. He got seen by a nurse practitioner. He got checked in by the receptionist, checked in by the nurse who took vital signs, asked some basic questions, and collected some samples. And then he was examined by a nurse practitioner who took an additional history, performed a physical exam, recommended a treatment plan, gave us our prescription. And he had a strep test, which ended up being positive. And so this was our bill, right? So the bill for the strep test itself, interestingly, was $86, which was a big surprise to me because I used to work at the student health center and we charged $10. So that was a big eye opener. And then the visit itself, which is kind of everything else, is just shy of $400. And so we see a couple of things here. So one is that's a really high bill, right? So, the total was like $485 for what was a half-hour visit at the urgent care center. But we have to acknowledge that that's paying for a receptionist, a nurse practitioner, a lab tech, the custodian, the nice new building that they've just built. It was a really cold day, so helping to pay the heating bill and the electric bill and all those types of things. All the supplies that were used during the course of that visit, and the thermometer thing and the looky in your throat thing and all that. But also the computers and the computer system, the electronic health record system, and it's also subsidizing the billing department and all of the financial people behind the scenes that do the work to then send me this bill. Certainly that nurse practitioner did not get paid $400, I promise you. But so not only are we paying for all of those things, but we're also paying for the half of people who don't pay their bill. So what you can see is that my insurance only paid $240. All right, so you see that insurance payment, WEA Trust. My insurance only paid $240 of that visit. I paid $25 as a copay when we first checked in, and then in the end, I still owed $220.77. I have good insurance, right, as a state employee. This is the good health insurance that we have in this country. Part of the reason is we have so many people who do not have good insurance or who cannot pay the patient portion of the bill, that when I pay this bill, I am helping to subsidize all of the bills that went unpaid, right? So if you think about it, since about half of them go unpaid, all the rest of us are basically paying double all the time, right? Because these are nonprofit organizations. They can't operate as a loss, but they're not trying to make money either. They're really just trying to break even. So we're all paying twice as much as we should be because half the time people can't pay their bills. All right, so that also is related to the issue of access. So we can break down access to healthcare into many different facets. The two that we're going to focus on this unit are can you get there and can you afford it? So the can you afford it piece has to do with insurance and your own financial situation and ability to pay. We're going to talk about insurance more in the next unit. Can you get there? Do you have a vehicle or is there public transportation that can get you there? Do you know how to get there? Do you know where you can go? And is there any place nearby? So one of the media assignments for this unit is talking about the problem of access in rural regions. So that's going to be interesting, I hope, for you to watch. The other thing that I'm going to mention as well when it comes to access to healthcare is, do you feel that you will be welcomed and treated appropriately? So we also see that in groups that have been historically discriminated against and sometimes even still modern day discriminated against do not want to seek healthcare of fear of discrimination or harassment, not necessarily unjustified either. So we often see people of certain racial and ethnic minorities or people who are LGBTQIA don't tend to access healthcare as easily or as readily as other groups where people aren't worried about that problem. So something else to think about. Next thing we're going to talk about is quality. So what's going on to make sure that the care you get in a hospital or a clinic is of good quality. There's a lot in the book about this, so I'm just going to add a few things that I think are useful. The first thing that I want to mention is that quality of care is really difficult to measure. So you as a patient didn't go to medical school, you didn't do residency, you don't know what the best diagnostic test for, a sore throat might be, or for someone who comes in with fatigue. You don't necessarily know what the best antibiotic to treat strep throat is. You shouldn't have to, right? But so your ability as a patient to assess the quality of care that you are being given is not awesome, right? Because you don't know, right? If an electrician gave me a plan for this is how I'm going to redo your wiring in your house, I don't know, right? I don't know if it's any good, right? So patient surveys and patient satisfaction surveys, although they're frequently used in healthcare, they are a little bit problematic, right? And so what we see in general, and so these kind of things come up again and again, is the things that patients tend to rate highly is if the doctor is kind and personable, somebody that you really like, if the doctor spends a lot of time with them. If it's a white male, they tend to feel like, oh, that's somebody who really knows what they're doing, right? And if they're neat and good looking, they tend to rate them more highly than people that are not particularly attractive. Also, interestingly, patients rate overweight and obese physicians as far less competent than typical weight physicians, even though the actual care delivered was the same and sometimes even superior. Right, so there's all these things that go into patient satisfaction surveys that are not actually good indicators of quality of care. Patients also really like doctors who will give them antibiotics, even though oftentimes that is not the appropriate medical care for what the patient came in with. But the patient's like, yes, this is going to make me better because they believe that it will, and so yeah, so it's tough sometimes. So what else can we look at? So if patient satisfaction surveys, they help you know about the kind of your customer service aspect of things, and that's an important piece. We want to make sure people feel cared for, but are they actually well cared for is the question. So outcome measures are looking at things like, okay, what percentage of patients in your practice have their blood pressure controlled, right? So of all your people who have high blood pressure, have you gotten their blood pressure levels back to normal by treatment with exercise, diet, and medications, right? What is the death rate in your practice? How well do you make sure that all of the children who come to see you are up to date with their vaccination? So what's your vaccination rate of your people in your practice? So these are all outcomes measures. They're data driven, and so they're objective and relatively easy to measure, especially with an electronic health record. But the problem is that's not entirely within the clinical team's control, right? So whether or not my patients are all fully vaccinated in part has to do with how good of a job am I doing explaining to them the reasons for vaccination and making sure that I check and see, ooh, is somebody falling behind? Ooh, what are they due for? Those are things that I can control. But some people are just fundamentally opposed to vaccination. And if I happen to have a lot of people like that in my practice, that's not necessarily because I'm not doing my job, right? And same thing with blood pressure example. So if I have a cantankerous older lady who's like, I don't want to take my blood pressure medicine, I don't care if I die, I die. But then my colleague has this lovely elder gentleman who says, yes, doctor, whatever you recommend, absolutely, I will do it. Well, they're going to have better numbers than I am. Their data is going to look better than mine. And so you can see that it's really tough. People who work in education talk about this problem as well. If they're judged just based on the test scores, but there are all these other factors that influence how their students do. They're completely outside their control, like are they getting enough to eat? Are they getting enough sleep at night? All those types of things. What's the environment like at home? Then it's problematic. So outcomes measures are useful and they are used in medicine. There are a lot of pay for performance initiatives and other things, but they're tricky. So another way that we assess for quality of care is through peer reviews and institutional reviews, and these take many different forms. So one is periodic chart reviews. I have never worked at a practice or in a setting where we didn't, with some frequency, get assigned chart notes from one of our colleagues, and we had to kind of go through and assess them using a rubric, make sure it seemed like their documentation was sufficient, that the diagnostic conclusion and treatment that they came to was appropriate. So we do that all the time. We find mistakes, we find omissions, and we report that to each other so that we can all improve. So that's a regular occurrence. That's part of standard medical practice that we do peer reviews on a really regular basis. Another common thing that occurs is something called morbidity and mortality reports. So you might remember the word morbidity refers to disability. So if somebody is ill or unwell or loses function, whereas mortality is death. So what these are anytime a bad outcome happens, usually this is in the hospital setting, where something didn't go the way it was supposed to. So somebody had a complication or a bad outcome, then the team that took care of the patient puts together a whole report and goes step by step through the case and everything that happened and identifies all the places when something went wrong. And the goal then is to be able to kind of identify these things so that then we can guard against them in the future. So this is a really well-known practice. It happens in the hospitals pretty much everywhere I've ever been. It's a very humbling experience to have to give one of these, right? Because you're having to confess to all of your colleagues that your team messed up and the patient suffered because of it. But this is a really important piece of accountability and making sure that we ensure quality. Another way we can assure quality of care is through incident reports. So if, for example, a nurse accidentally gives the wrong medication, we fill out an incident report. If a patient slips on the hallway and hits their head, we fill out an incident report. The goal of these is not so much so to then blame the custodian who left the floor a little slippery or the nurse who was too distracted for whatever reason and gave the wrong medication. The goal of incident reports is to identify potential systems changes that we can make. And so in this unit, we're going to start talking about systemic thinking, which is actually our last unit, but you're going to start to hear about it a little bit. So what are ways that we can help prevent these errors from happening? What are the ways that we can remove the potential for human error? What are the ways we can make it easier to do the right thing and harder to miss something or make a mistake? So there's a lot of things that you can do at the organizational and systems level that can help people perform at their best. So there's a really good video by Atul Gawande, who is a physician who has researched this extensively as part of your immediate assignment. So the last piece is coordination of care. This is a pretty tricky piece in the United States because we have this very fragmented healthcare system. They don't all work for the same people. In fact, they all work for lots of different people, and we have small organizations and large organizations and all kinds of things with no centralized framework at all. Nobody is in charge. Not a one, right? It's all just, I think I'll open a hospital. Okay, fine. And it might drive out the nearby hospital, right? It might drive them out of business, might not. I don't know. It depends, right? It's all haphazard. There's no centralized organization at all. Other industrialized nations, for the most part, have some sort of a national health service or national health system. that in most cases provides a tax-subsidized, no or low-cost point of care system. So to go to the doctor, to get a surgery, whatever, usually it costs nothing or very little because it's subsidized by your tax dollars and other people's tax dollars. So that's really interesting from an access standpoint, but it also is really interesting in terms of a centralization and coordination standpoint. So oftentimes that means they're all using the same computerized record system. They are all reporting to the same data collection systems. And this is very different from what we have in the United States, where everybody has a different system. Even different state health departments have different ways of collecting data. So the different categories of ages where they're collecting their COVID numbers, for example, vary from state to state. So then we can't put it all together nationally because it's all different. Okay, but that's public health. We'll get to that later. All right, so some of the three main challenges that we have to coordinating care in the United States for patients are, one is medical records. So most practices now have some form of electronic health record. There are hundreds of different software programs out there for medical records, and every practice kind of has a different one. And even if, for example, so like Mayo Clinic Health System and Prevea both use the same software program, they both use Epic, but they're two different instances of the software, right? So so another example is, when I worked at Student Health Services, we had an electronic health record system, but it was a completely different software system. And so when I referred someone to the surgeon, because they thought they needed their appendix out or their tonsils out or whatever it might be, even though we have all this electronic data, we had to print it out, fax it over to the surgeon's office, and then the surgeon can read it on paper, sign it, and then it gets scanned in as a document into their health record. So we do not have a seamless way to integrate health information from different systems. People are working on this, so there are some organizations now that are saying, okay, you use Epic, we use Epic, let's sign an agreement that says if I'm referring a patient to you, or you're referring a patient to me, we'll figure out a way to be able to synchronize that information and transfer it from one system into the other, copy it from one system into the other, so that we have that full accessibility of the way to kind of filter and organize the information. So people are working on it, but it's really tough when we have all these different proprietary software systems. The other is insurance coverage. So perhaps you need your tonsils out, and I want to refer you to the surgeon, Dr. Herman's, great surgeon here in Menominee, but your insurance won't cover that, right? So maybe your insurance will only cover a physician who's back home for you in La Crosse. Which, if it's a surgery that you can kind of do at your convenience, that's nice. But if it's a surgery that is urgent, then that's difficult, right? And so sometimes we've had patients who were severely ill, even, that we, for lack of better options, bundled into a car for a 4-hour drive to the healthcare organization that their insurance was going to cover. So that's a challenge. That's a real challenge. Finding specialists and organizations that will take your insurance aren't always convenient, and they don't always coordinate with where you got your primary care. And then finally, privacy concerns. So HIPAA, which is the Health Insurance Privacy and Portability Act, says that I cannot, as a healthcare provider, release your protected healthcare information unless you give me direct permission to do so, or it is required for continuation of care. So, for example, if I'm sending you to the emergency room because I think you're septic, I can go ahead and fax records from the visit that you just had with me, and here's what happened, and here's what we did, and here's what the lab test results were, so that the hospital staff will have access to all of that information at their fingertips from a fax, right? I can. But for example, let's say you went to the emergency room on the weekend and they put in some stitches and they said, okay, follow up with your primary care doctor in 5 days to get the stitches out. Well, if you don't tell them who you're going to see because you haven't made the appointment yet and it's the weekend and all that kind of stuff, then usually when you show up to my office 5 days later, I don't have those records. I don't know that they wanted your stitches to come out 5 days later, right? And so then we have to call and say that the patient is here, because a lot of times if we call and you're not there yet, they say, well, we don't know that the patient's actually coming to you and we don't have written permission to give you the records. So sometimes privacy concerns can make things a little bit more difficult for information to flow back and forth. Privacy is super important. We always want to maintain that. No one ever should read a medical record unless they have a medical need to know, unless you're directly caring for that patient and need to know that information. But sometimes it can make it a little bit more difficult to coordinate care. That's it for healthcare organizations from my standpoint. There's some additional material in the book and some really good videos. I hope you feel the same way for your immediate assignments. So talking about all the different types of healthcare organizations that we have, a little bit about how they get paid, which is important for understanding access from a financial standpoint, but then we also talked about from kind of a geographic and transportation standpoint, what are some of the measures in place to help ensure quality care, and then some of the challenges that we have with coordinating care between all of these different healthcare organizations. All right, thanks so much.